It's less of a problem now because there are some really good drugs available that don't require lab work and don't require monitoring, and like Pradaxa, that don't require patients to continue to get their Coumadin levels checked. But having said that, I think that if you have one of these 200 physicians that Elena is talking about, if you have a caring and involved physician who knows how you feel about this and is willing to be a partner in your care with you to try this, I can't see how that's a negative. Now, if you're asking, do you have to get the approval of your primary care before you move ahead, I think that would probably be no, is the answer to that question.
And one second question. If you have like progressive MS versus just primary MS, the rate of the vein, let's say, closing earlier,
Yep.
is there more at the rapid rate of the progressive person with MS, or if the person is at the early stage, that rate of the narrowing of the veins will be less?
No one knows the answer to that question yet.
Okay.
What we have seen is that patients who are very far along, so very debilitated progressive MS, they do seem to have more abnormalities, more significant abnormalities in their veins, okay? So that's one point. The other point is that we know from prior people's work that the patients who seem to respond best to angioplasty are patients with relapsing remitting MS. That's to say they don't have as prolonged or as durable a response. We have seen improvements in patients who have some form of primary or secondary progressive MS, but our results agree with what other people have described in that it seems like the less symptomatic patients are, the more likely they are to be able to benefit from the procedure. There is one trial out there that was done by a physician named, oh boy, what you're describing is a clinically isolated syndrome. And yeah, and this physician found that there was a statistically significant correlation between the presence of CCSVI and patients who have CIS. Those are the only, I can tell you the name afterwards if you want to. I'll pull the name out of my laptop. The trial that he did was interesting because he compared patients with, using Doppler studies, he compared patients with CIS and normal controls and found that there was a significantly higher rate of CCSVI in patients with CIS. So that partially answers your question in that patients with CIS can have CCSVI and probably should be expected to have a higher rate of CCSVI. The longer question is if a patient who's had one episode of symptomatic of symptoms, should they be treated? I don't think anyone can answer that question for you because no one's done a trial to look at CIS versus most physicians who are doing CCSVI angioplasty don't consider CIS to be, as you know, don't consider CIS to be MS.
Yeah, exactly. Thank you.
Okay, just a quick question. Can MRV results be achieved with the standard MRI machine or no?
The machine has to have the a high enough field magnet to allow you to get the resolution that you can get, that you need to look at the blood vessels.
Okay, so most neurologists then
Most
would
neurologists now have access to machines that are, the way we grade MRI machines is how much bigger their magnetic field is than the magnetic field of the Earth. So a 1 Tesla magnet is the Earth's gravitational field, basically. And that's kind of a low-level machine. And most people who are doing high-end vascular work have at least a 1.5 Tesla magnet. The work that Hackey's described and that the Hubbard Foundation talks about, I believe most of it's done on 3 Tesla magnets, which is 3 times the Earth's magnetic field. Now, does that mean you need to have a 3 Tesla magnet to get that kind of resolution? Probably not. Probably 1.5 would work, and most neurologists probably do have access to a 1.5 machine, or their radiology group does.
Not in Canada. There's only 3 machines that will do that in Canada. That's one of our problems in Canada is that we do not have the machines up to date. They're antiquated, they're dinosaurs. That's one of our problems.
Yeah, I'll defer questions about the Canadian system to people like Steve, who can definitely answer you better. But I'll also tell you that I wasn't kidding when I told you that I find MRI I read MRAs from other parts of the body, but I find the physics involved in generating it's incredibly complicated. I spent years trying to figure this stuff out. Frankly, I'm glad I'm glad I'm a plumber, because it's really, really complicated physics. And if you ever have an opportunity to listen to either Clive Beggs or to Hubbard or Hackey or any of these guys give a talk, they give a really nice explanation of all the benefits of MRV. And you can't deny that there are benefits of MRV. I agree with that. I'm just from a practical standpoint stating that even if it's not a matter of not having the resource available, the MRI available, the machine available, in order to get the imaging done at the level it needs to be done, it's expensive. It's a lot of money. And I'm not sure that we don't need to find a cheaper way to do it. Whether it's with MRV, a cheaper MRV, or with ultrasound, I think we need to find a better diagnostic tool.
So what's the range of cost at the Rhode Island Institute for treatment? And are subsequent follow-up scans included, or are they extra?
I've tried very hard to beg off questions like that,
Okay.
and because I don't think they're really appropriate for this setting. But I will
Okay.
tell you this: they're the lowest amount that any group in the United States can charge for any procedure that they do is the Medicare rate.
Okay.
And what we've tried to do is match the amount that we charge at Rhode Island Vascular Institute for everything: the ultrasound, the MRI, and the ultrasound, the venogram, and the treatment to the Medicare rates. So. I don't know if that really helps you, and it's dodging your question, but you can talk to Elena later if you want to about that sort of stuff.
And just to comment on that, we also include the ultrasound in our procedure cost. And we include the follow-ups by phone, our nursing consultations, and all of the 1 month, 3 month, 6 month, and 1 year, and each year after that. We're looking forward optimistically that we'll be checking on you once a year for the next 10 or 20 years, hopefully. So we have a question over there.
First of all, I'd like to say that I'm not receiving any money from Rhode Island Vascular. I had the procedure done February 10th. I had hoped for more, but it was more than I expected. So anybody that's considering it, the incision, if you look at the pin, the incision in your thigh actually is probably smaller than the opening of the pin. I was on a down slope. I was diagnosed in 01, but we've actually had it since 1990. Just didn't know it. I have found that I am on an even keel. Some people have had a lot better results than I had. As the doctor said, there can be problems. I do have a blood clot now in the right jugular. If I had to have the procedure done again, knowing what I do know now, I'd do it again. And the video of Rhode Island, I'm glad I saw it, because I missed going from the recovery room or setup into for the procedure. I don't remember going over there, tell you the truth. That was a happy camper. But everything you said, they are tremendous. As he said, they do go through every procedure prior to, so there's no question. They're not just going to say, oh, here's your money, got your money, okay, procedure's done, goodbye. And they do call. I don't remember in 6 months whether I did get a call. I'm not sure about that. Anyway, it's worth it, people.
I like questions that start with that. I'm not getting paid. Scott is not there anymore. No. Scott moved on to Green. Scott used us as a launching pad for anybody who got to know him. He was our lead nurse, but very, very nice guy. Scott's born.
I have two questions. The first, on the Doppler ultrasound, what is a B mode abnormality?
Okay, that's a great question. You were reading the slides very carefully. That's great. B mode is bright mode, or B mode is the grayscale imaging that I talked about. So a B mode abnormality is looking at the structure of the vein itself and seeing an actual abnormality in the structure of the vein. So whether it's a valve that's not moving, or it's an area of narrowing, or an area of a stuck valve cusp, or a blood clot inside the vein, an abnormality that I can see on an image, an actual image that shows me the abnormality, as opposed to flow studies, which can be either color flow or Doppler studies. They're really what are computer-generated information. The ultrasound machine for flow studies is bouncing a sound wave off of red blood cells, and then it's taking the information from that, the speed and the frequency of the blood cell, and making it into a color, and then it projects it as a color. And it applies that color to the space where it bounced the sound wave off of. So that's kind of like computer-generated information. The B mode is an actual image, an actual ultrasound image of the vein itself. That's the grayscale part of things.
My second question is, can you comment on information I've heard about they're looking at doing, I don't know if they're doing a study, you're looking at doing a study or whatever, of treating it by bypass?
There was a lot of discussion of that for about 15 minutes at the, I mean, that's a long time, believe it or not, at the CCSVI symposium in New York City this past July. There are a couple of Italian vascular surgeons who are suggesting that bypass surgery might be the way we need to go if we're seeing such significant narrowing. I don't know that any further work has come out of it. I mean, it sounded like there was interest, at least on that side of the pond, in doing this sort of thing. I think we need to, try not to reinvent the wheel here. We know that there are a lot of reasons why endovascular, so interventional radiological approaches to blood vessel problems, are safer, faster, and frankly cheaper than doing bypass type surgeries in other parts of the body. We've learned this over the past several years. It's actually why most vascular surgeons now do most of their work with catheters as opposed to doing open bypass procedures. So I think that it's probably going to bear out in CCSVI as well, but there's still room in the vascular world for bypasses when endovascular approaches don't work. And I think that that might be the place where they end up being used more often than not if all the science does prove that CCSVI is somehow causing MS.
I have two questions here. The 4 grades that you spoke of the blockages, is there a time frame that you've seen? I assume, maybe I shouldn't assume, that they may move from a grade 1 to grade 2, grade 3 to grade 4. Is there a time frame that you may have seen that occurs?
My assumption is yes, but it's an assumption only because I haven't taken a patient who had a grade 1 venographic abnormality and kind of left them alone and then brought them back in a couple months and looked for a grade 2. So in other parts of the body, when there's an abnormality in a blood vessel, it tends to change the flow pattern through that area enough, whether it's because the valve's abnormal or there's a web across that area. If it changes the flow enough so that those really special cells that I was telling you about on the side of the vein, they recognize it as abnormal flow. They recognize it as turbulent flow as opposed to what's called laminar flow. That means that instead of the flow going smoothly across the surface of the lining of the vein, it's getting stirred up in the area where the abnormality is located. And that stirred up blood flow in the area causes shear stress across the, and what we found in other parts of the body is that shear stress on the lining of arteries and veins is what causes them to start changing into scar tissue, intimal hyperplasia and areas of narrowing. So the assumption would be that if you don't fix the cause of turbulence,